here. Mostly, okay, a little bit on the pressure, but mostly on the cardiac output in these conditions, and of course, as a consequence, limit the increase in lactate levels. The same is true here in another model of hemorrhagic shock. You see that indeed the amount of fluids was quite limited, minimal impact on blood pressure, but an increase in cardiac output by this impact on venous return. So it seems quite promising in these conditions. Do we have data more than just these sparing? Well, maybe in outcome, but in animals trials, we have a lot of things that improve outcomes. So we need perhaps to look at human data. We do not have a lot of data. We have some data coming from India, 2 studies here, where this was used in hypovolemic shock. And many of these patients were also with diarrhea, and this is the source of hypovolemic shock in these conditions. And so what they have is some decrease in use of vasopressors, and the shock index that was indeed lower in that group compared to the other group. And more patients reaching the blood pressure more rapidly also. And in the other trial here, you can see no major difference here, or you don't see no major difference in the group at baseline, but what the effect was, well, minimal effect on the amount of blood, perhaps a trend for the vasopressors, but slightly higher blood pressure in these patients, and more patients reaching the goal, and lower blood lactate levels in the group receiving the alpha-2 agonist compared to 0-1. No major other impact on mortality, but you can see mortality was very low in these trials, of course. So at the end, which type of shock would benefit most from venous constriction? Obviously, hypovolemic and distributive shock, whereas the impact on the venous compartment may be interesting there. Cardiac shock, maybe not, because you will increase preload of the right ventricle, and this by the left ventricle, this may not be the best thing to do. So in conclusion, venous constriction is an important component of the hemorrhagic effects of our vasopressors, and we often neglect it in the past.
So let me then go towards the venous side. We've had Professor DeBacker talk about it, and I'm going to talk about some newer evidence here. Normal physiology on the left side of the screen, venous pressure, intravascular volume, we all know this, venous return. Take the example of hypovolemic shock, decrease intravascular volume, decrease venous pressure, venous return decreases, preload, blood pressure, cardiac output follows, and decreased tissue perfusion. So what can we do to correct? We can either increase intravascular volume, but in septic shock, the tank is already so big, I don't know where we're going to go. In hypovolemic shock, either there's bleeding or there is severe hypovolemia. We can give more fluid, but we can also cause vasoconstriction. So Professor DeBacker talked a little bit about how there's vasopressors, but the problem, or the good and bad about vasopressors, is that they do affect the arterial side of the circulation more than the venous side. We are looking at this new agent, Centhaquine citrate, that was briefly talked about. So alpha-2b and alpha-2a action. The venous circulation is rich in alpha-2 receptors, as we've already discussed. So what this agent does, theoretically, increase venous tone, vasoconstriction, increase venous return, increase preload, and then decrease sympathetic outflow that's going to cause vasodilatation, decrease SPR, and help improve forward flow. Very new agent, but the evidence so far, most of it comes from small trials and studies in India. It's interesting. Without going into too many depths here, the preclinical work, we've already shown that. Daniel showed some of that. Phase 2, Phase 1, Phase 2, Phase 3 has all been done, but very small sample sizes. 25 healthy volunteers in Phase 1, showing a wide safety margin. Maximum tolerated dose about 10 times the therapeutic dose, which is always good news. It shows a wide margin of safety. Short T-half, so about 0.7 to 1.5 hours is this plasma T-half. Followed by Phase 2 trial in 50 patients with hypovolemic shock. Outcomes being improved blood pressure, improved lactate, and an improved base deficit. And well tolerated, as again in the Phase 2 trial. Phase 3 trial, bigger trial, randomized trial, 105 patients with hypovolemic shock and a placebo arm as well. Interesting part, about 9% reduction in 28 days, all-cause mortality. However, this was a non-significant difference and the trial was not powered for mortality. So the data is very interesting and very encouraging.